Sometimes it will be here, no? Not sure about that. Right. So first is so again, don't forget about the giving the IV fluids, right? So when you first phase one, we don't have blood, so we start the IV fluid initially, right? When the cannulas resuscitate IV fluids and start giving the blood products, right? So next come to the endoscopy. So as I said earlier, so you think about the patient need an early urgent endoscopy or not, right? So when the Bedford score is 0 or 1, so you can think about discharge early. Others are getting admitted. So when there is a major bleeding, then after initial resuscitation. So first is the resuscitation, whatever, right? So first is to stabilize the patient, resuscitate, and then the very major heavy bleeding, then we think about the urgent endoscopy, right? So others are getting the endoscopy within 24 hours. So there are the various the recommendation when the patient is within 12 hours, 24 hours, something like that. But anyway, the general recommendation is 24 hours within the admissions, right? Right. So again, we are going to divide here into the two parts. So the patient is managed for the non-varicose or varicose bleeding. So it depends on the endoscopic finding. Right. So I'm not going to detail about the non-varicose bleeding management. Right. But anyway, I've just highlight the important facts. So in non-varicose bleeding, so like a vertical disease, right? So the endoscopic treatment, right? So it's recommended not to use the adrenaline as a monotherapy, as injection, right? So the surgical team are more familiar with these things. So they use the mechanical clip with adrenaline or thermal coagulations with adrenaline or thrombin adrenaline. So anyway, I just wanted to highlight these are the main treatment options. So you go into the varicose bleeding, all right? So even before the starting the endoscopy, okay? So we are thinking about giving other pharmacological treatment for this aspect of varicose bleeding, right? So especially the patient with the chronic liver cell disease, right? So there are the recommended the treatments are so, and one is the terlipressin, right? So this is a vasopressin analog, right? And the one is the somatostatin, right? So that means vasopressin is a vasoconstrictor, right? So is the terlipressin is an analog, right? So terlipressin does have a mortality benefits, right? And reduce the bleeding also. So that means these drugs are increase the splenic vasoconstriction and reduce the portal flow and reduce the bleeding, right? So as well as when there is vasoconstriction, the other organ also perfused, right? But still, as we causing the potent splenic vasoconstriction, it can cause other vessels also. So that does mean when the patient has an, especially when vascular disease like myocardial infarctions, right? So be very cautious. Basically ischemic heart disease, but it doesn't mean ischemic heart disease patient doesn't can't take terlipressin. They can take, but when there's ongoing ischemia, it will be a problem, right? So earlier also you heard about the vasopressin. When I was in HO, I used vasopressin, but it's not available. I don't know. Right? So the vasopressin also the same effect, but it doesn't have a mortality benefit like a terlipressin. So it is not recommended generally nowadays. Right? Vasopressin is the one recommended. So we are giving like a 2 gram USD in this process. So these are injections. right? Not the infusion. And so it can be given until the definitive hemostasis is achieved or up to 5 days. Right? The somatostatin also, we have the analog, what we call the octreotide. Right? This is available in our setting. Right? Still sometimes not available all the time. We need to take from other hospitals. Right? So the dose is like have also mentioned here. So it's 100 microgram. So the set dose, right? And it's followed by the 25 to 50 microgram infusions. Right? So, right. And the prophylactic antibiotic. So the prophylactic antibiotic in this patient where is still bleeding, shown to be a moderate benefit. So we can use like an third generation third generation cephalosporin, right? So like a ceftriaxone, ceftriaxone, right? So even you can use the tazobactam. If you penicillin allergic, you can even consider oral ciprofloxacin also. So we are doing endoscopy now, and we found that esophageal or gastric varices, right? So the main therapeutic option there is the band ligation. So everybody know about it. Right? So when there is heavy bleeding, even with the vein ligation, right? So there are other options like tips, the transjugular intrahepatic photosystemic shunts. But it's not available in our centers or maybe in the specialized settings. So until the surgical options are available, even the tips or any other, even the liver transplantation, right? And it's available. So the temporary measure is the balloon tamponade, right? So it can use in the esophagus or the stomach, right? So the balloon is inflated endoscopically, but once you remove the high chance of bleeding. So we are waiting for some other surgical options, and until that we can use the balloon tamponade. So there are for the gastric varices we can ban. So we use the injection techniques. Right. So when there is when initial endoscopic treatment fails, we need to rethink about the re-endoscopy, right? So for the treatment, endoscopic treatment, or as well as to decide whether we're going for an urgent surgical options, right? So otherwise, you know, think about the patients need an urgent interventional radiological options. So anyway, just to summarize the treatment options we discussed here, right? The vasopressin, right? So when importantly use the vasopressin, it is recommended to use the IV GTN along with the vasopressin to reduce the ischemias, right? So otherwise, now as I said, nowadays recommended is a terlipressin, right? So next one is the somatostatin or octreotides. Okay. So anyway, we have discussed these things, right? The final option is the liver transplantation. Right. So still there are a few important facts we need to discuss. So this is about the controlled bleeding and prevention. Free bleeding patients who are NSAIDs, aspirin or clopidogrel, right? So the common scenarios we may encounter. So what about the aspirin? Yeah, we can continue with aspirin, right? So low dose is low dose aspirin, 75 milligram for the secondary prevention of other vascular diseases, right? So once we can continue once the abdominal bleeding and hemostasis has been achieved, right? Stop all the NSAIDs, and but what about the clopidogrel and other antiplatelet agents? Yeah, then we need to discuss about the risk benefit with the specialist, like a cardiologist or whoever treating the stroke, right? So especially there will be a problem when the patient has a recent coronary artery stents, right? So we need to think about their benefits and everything, right? So, but because there's no definitive recommendation for when the patient who has clopidogrel or other antiplatelets, right? It is individualized. So I just going to touch upon is what are the imaging modalities in addition to the endoscopy we need for the chest X-ray. So when you think about any esophageal perforation, yeah, right? And abdominal X-rays. So the supine erect films. So when you think about any bowel perforations, right? The CT and ultrasounds, yeah. When we think about any unusual causes, because we can't find any varices or ulcers in the scans, but we need endoscopy. So, especially when you think about the when patient having any malignancies, yeah, for example, right? Okay. So, we heard about the mesenteric angiography. Everybody? Yeah. So when we can't find the bleeding spot in endoscopy, right? So we can send the endoscopy up to this maybe we can bleed beyond that also. So when we can't find, so we need to think about the mesenteric angiography to find the bleeding spot. So it can be compared with the interventional radiologist for their transcatheter arterial embolization. Right? Sometimes even we don't find it. Recently we had a patient also. They undergone mesenteric, but still we can find. But the thing is, it should be done early as possible. Right? So are there IV options like nuclear medicine scans also helpful, but it's not available in our setting. But, yeah, I think